Hi, welcome back. Let's spend just a couple more minutes talking about some additional drugs that you're more than likely going to encounter as you move forward. And the first one I think I'll make mention of is Ultram or Tramadol. Kind of funny. Ultram is a Schedule 4 controlled substance now. And when it first came out, it actually wasn't a controlled substance. And some of the initial studies had suggested that its pain relieving effects were about equivalent to that of Tylenol with codeine. So tells you it's not all that great of an analgesic, but nonetheless, when you look at the structure of tramadol, which is shown here on the left, I hope you can start to speculate on how this particular drug might bind and activate an opioid receptor. And yes, when you look at tramadol, it's going to mimic then that tyrosine group in the endorphins or enkephalins. It's going to be a T site binder. And in order for it to have the best activity, that methoxy group ought to get oxidatively removed by CYP2D6. And that affords us with something called the M1 metabolite, or that's O-desmethyl tramadol. Right, so tramadol itself has some activity, and then its metabolite has activity as well. I wouldn't say it's a potent analgesic. It's not very potent at all, but it is used quite frequently in the community setting. And there's an immediate release formulation, and then there's an extended release formulation that patients needing chronic pain relief take maybe just once a day. What's interesting about tramadol is its ability to inhibit the reuptake of various neurotransmitters, in particular serotonin and norepinephrine. And this particular attribute of tramadol has been suggested to actually contribute to its pain alleviating effects. And having the ability to inhibit the reuptake of, say, norepinephrine in the ascending pathway might actually then contribute to a decreased sensation of pain. But nonetheless, there's tramadol. You can see, you can speculate how it might bind. There is a tertiary amine that will get positively charged at physiological pH. Here is an alcohol that you would expect then to H bond, and then this methoxy group, of course, is going to become a phenolic group, which will H bond as well. And I don't have it in this particular slide deck, but there's a drug called Nucynta, and the generic for that ends up being tapentolol. And tapentadol is it's structurally related to tramadol. However, it's more potent. And on top of that, it's pretty expensive. So we don't see a lot of it. But when I look at the structure of tramadol reminds me a little bit of tapentadol or Nucynta. Have you seen this used? I know of one or two patients that I have receiving this molecule, Nucynta, in the community setting where I work. And it did require prior authorization. Surprise, surprise. All right, moving forward. Tramadol binding. Again, after tramadol gets metabolized by CYP2D6, we get the M1 metabolite. There's the alcohol, there's the positive charge, and so on. The rest is history. Right? Other agents, again, fentanyl, sublimase. This is an interesting molecule these days, to say the least. Now, fentanyl historically has been used in the hospital setting as an induction agent. So when people needed to be put out because they needed to be intubated, or they needed to be put out because they are going to the OR, so we're getting intubated again. Fentanyl was a great drug to induce them. Fentanyl found its way then on the units, the step-down ICUs and the ICUs. And now you find fentanyl pretty much anywhere and everywhere, unfortunately. And the illicit production of fentanyl and then the contamination, intentional or unintentional, of other street drugs with fentanyl has caused a lot of problems for a variety of individuals who unfortunately are dependent on drugs. But nonetheless, fentanyl and its derivatives belong to a class of drugs called the 4-annalylpiperidines. So this is an aniline, so it's an aromatic amine. And then this six-membered heterocycle is a piperidine. So this together then is a 4-annalylpiperidine derivative. Yeah, fentanyl itself is very lipophilic. So after IV administration, it will get into the CNS very rapidly. And then after it gets into the CNS, it can bind opioid receptors, activate opioid receptors, and then come off opioid receptors. It has affinity and it has intrinsic activity, but it's got a relatively short half-life. And so it doesn't stick around all that long compared to, say, something like morphine. Okay. Uh, Fentanyl, there is fentanyl and then remifentanil. These are derivatives of fentanyl. And these drugs, again, are also used for in the surgical suite. They aren't used up on the unit and they're not used in the outpatient setting. Okay. So fentanyl. When you look at the, come on, metabolism of fentanyl, again, to it rushes into the CNS, binds, comes off, and then as it circulates, fentanyl can get metabolized by a variety of different routes. And if you look at the route going counterclockwise, the first thing you'll notice is that we can actually have an N-dealkylation reaction occur. Or if you go clockwise, what you might end up seeing is an oxidation reaction occurring, whereby that methyl group gets oxidized and an alcohol is in place. And then that particular metabolite can undergo N-dealkylation, or this particular N-dealkyl metabolite can get oxidized as well. And all in all, what you're going to notice is that CYP enzymes are largely responsible for the metabolism of fentanyl. And I wanted to double check really quick while I have you here as a captive audience. Yeah, metabolism, CYP3A4, norfentanyl. That's what I was struggling with in my advanced stage. So N-dealkylation will forge you norfentanyl and other hydroxylated metabolites. So we don't really need to worry about the intricacies of their names, mostly because I can't remember them anymore, but it doesn't matter. CYP3A4 is responsible for the metabolic route for fentanyl. Okay. All right. Question: can we reverse the effects of an opioid? Can we reverse the effects of morphine or fentanyl or hydrocodone? And I know you know the answer to this question already because when we talked about the structure activity of the opioids, I told you that if you put a cyclopropyl group or perhaps a cyclobutyl group or a double bond and a allylic group at the top of the molecule, you convert the agonist into an antagonist. And I also said that it was a pretty important discovery. So what we ended up with is a molecule that is referred to as naloxone. Naloxone, or Narcan, which everybody should be familiar with at this point in time because it's available over the counter, is a pure opioid antagonist. This molecule has very high affinity, so high that it will displace morphine from its binding site. All right. It has very high affinity, but guess what? No intrinsic activity. All right, so it's a bona fide antagonist. Look at the structural features of naloxone. You see the alcohol at the 3 position. Here's a carbonyl group at the 6 position, and there is no double bond here between 7 and 8. At the 14 position, we have an alcohol as well. So all of a sudden, this is starting to look a little bit like oxymorphone. Okay. The difference rests with this group up here coming off the amine. It's critically important. When naloxone binds to opioid receptors, it does so with high affinity, but the presence of this allylic group, this is like a cog in the wheel. It prevents a conformational change from occurring at the receptor level. And if that conformational change can't ensue, the G protein isn't going to get activated, and we're not going to displace and separate the alpha subunit from the beta gamma subunit, and the alpha subunit in your mu opioid receptor isn't going to go inhibit adenylyl cyclase, and the beta gamma subunit isn't going to go and modify or modulate potassium and calcium channels. So the presence of this allylic group, it prevents conformational changes. When you happen upon an individual that is unconscious and has shallow, low respirations and maybe pinpoint pupils, you might surmise that they are suffering from some type of opioid intoxication, and that may warrant the administration of Narcan. If it's a person that you happen upon in the street, and you have the nasal spray, you give the nasal spray. If it's an overdose in the hospital, unintentional, that may require some low doses of Narcan to restore respiratory drive. All right. But when you start to pour in naloxone and you're not getting a response, and they're not coming back or showing signs of uh, increased respiratory drive, then you really need to start considering, what else could be the intoxicant at that point. All right. And then let's end with this molecule, buprenorphine. Are you familiar with buprenorphine? Have you seen this particular molecule in your practice setting? My guess is yes. And buprenorphine is used extensively today, but most often in individuals who suffer from opioid use disorder. My experience with buprenorphine is primarily in the dispensing of Suboxone, which is a combination of buprenorphine plus naloxone. And we dispense a lot of the films that are used sublingually. And again, those are for individuals with opioid use disorder. Buprenorphine's structure is shown on the right, and it is a derivative of thebaine. Remember, thebaine is one of those alkaloids that you find in the latex of the poppy plant. And buprenorphine is a partial mu agonist. All right. It's a partial mu agonist, but I will tell you that it has an amazing affinity for the mu receptor. Right? It has very, very high affinity. All right, but decreased intrinsic activity, especially compared to morphine. Right? So, for example, if you had a patient who had recently injected heroin or took morphine, and then you gave them buprenorphine, it is quite possible that you will induce withdrawal symptoms in that individual because buprenorphine can slip in and bind in place of morphine. And when it binds for a long time. Okay. It has similar attributes to that of morphine. There is the alcohol at the three position, positive charge coming off the nitrogen at the northern area of the molecule. Notice that it does have this cyclopropyl group. And then we have this T-butyl group coming off the 7 position. Along with that is an alcohol methoxy group. And I'm not going to necessarily pinpoint any one particular chemical moiety, but it's the composite of all of those features that lend to both very high affinity here and here and here, but then the partial agonist effect is largely due to the cyclopropyl group and perhaps to a lesser extent the methoxy group. Okay. So we see this being used for opioid use disorder, but please understand that it is still useful for the treatment of pain. There is something called Belbuca. All right. And Belbuca is a an oral film, and patients can put these, and apply them buccally for the treatment of pain. And it also comes in patches as well. So we have buprenorphine patches that are used. You may be asking yourself, why can we use buprenorphine for the treatment of opioid use disorder? Well, it turns out that when a patient who is addicted to opioids takes buprenorphine in the form of, say, a sublingual film, they're going to get that activation of opioid receptors. They're going to get the quote unquote reward that they are seeking. Right? And what they're not going to get, though, is risks of respiratory depression that you see with, say, morphine or heroin. There's this quote unquote ceiling effect associated with buprenorphine. And as you increase the dose, you can start to increase the analgesic effects up to a certain point. And in doing so, you won't, though, increase the risk of respiratory depression. This is sort of what's being referred to as receptor biased approaches to um, opioids. Morphine can cause respiratory depression and analgesia. Buprenorphine can elicit some analgesia, but not cause the degree of respiratory depression. And what the researchers are starting to figure out is that opioid receptors can be differentially coupled to the inhibitory alpha subunit pathway, but then they also are coupled to a beta arrestin pathway. And depending on which pathway gets activated, will predict then whether or not you have analgesia and respiratory depression or just analgesia. And the goal here is to develop molecules that only interact with the GI pathway and do not necessarily employ the beta arrestin pathway because that's where the respiratory depression starts to come into play. Buprenorphine, CYP3A4, and also some glucuronidation as metabolic routes. You can see CYP3A4 will catalyze this N-dealkylation to give you norbuprenorphine, and then anywhere there's a hydroxyl group is essentially fair game with regard to a phase 2 reaction. Right? Even if we create a hydroxyl group on the molecule secondary to oxidative metabolism, once it's there, we can go ahead and start to add glucuronic acid to it. Okay, that's all I'm going to say about the opioids for now. Are there other opioids? Absolutely. Are there other pain medicines? You betcha. Which ones are you going to encounter? Well, I guess you'll find out. And you'll hear more about this later on. Talk to you soon.